دكتور معلش مرة تانية، 1 وكم؟
مثلا 1:10 تبغى نبدأ، بعد كده 7 دقائق.
أيوة خلاص ممتاز.
تمام. طيب بالنسبة للموجودين، لو حابين لو عندكم أسئلة حابين تبدأوا تكتبوا في الشات، يعني إيش حابين تعرفوا اليوم، إيش حابين نتكلم في إيش. لو عندكم أسئلة ممكن تكتبوها في الشات لو حابين.
تمام دكتور بإذن الله.
أيوة كده واضحة السلايد؟
أيوة واضحة.
تمام. طيب 1:10 إن شاء الله نبدأ.
إن شاء الله. طيب السلام عليكم جميعا، أهلا وسهلا بكم. Welcome دكتور خالد. Thank you in advance for your presentation. بداية أحب أقدم دكتور خالد. دكتور خالد الجعلي is an associate professor and faculty of pharmacy, infectious disease pharmacy, a pharmacist consultant, infectious disease pharmacy program director at King Abdulaziz University Hospital. Welcome دكتور خالد. Floor is yours. You can start.
السلام عليكم.
أيوة عليكم السلام دكتور. دحين هعملك هوست مرة تانية.
تمام.
تفضل.
المعذرة أنا خرجني، فلو أحد كتب في الشات أي سؤال معلش لو بس كوبي بيست ونزله مرة ثانية بعد إذنكم.
لا ما في أحد سأل سؤال دكتور.
ما في. تمام.
طيب دكتور بس السلايدز لأنها ما هي ظاهرة.
أبشري. هل كده واضحة؟
أيوة تمام واضحة.
تمام.
طيب بس أستأذنك مرة تانية يا جماعة، معنا دكتور خالد الجعلي. He's an associate professor in Faculty of Pharmacy, Infectious Disease Pharmacy Consultant, and Infectious Disease Pharmacy Program Director at King Abdulaziz University Hospital. Welcome دكتور خالد. Thank you in advance for your presentation.
Okay, thank you, Dr. Sabrine, and thank you for the kind invitation. It's my pleasure to be with you today. By the way, الريزيدنت الحاليين الآن موجودين من منطقة معينة ولا إيش النظام؟
إحنا من المنطقة الغربية
الغربية والجنوبية. ممتاز. تمام. طيب حياكم الله. طيب نحن طبعا التوبيك اليوم اللي هو الكاثيتر ريليتد blood stream infection والinfective endocarditis يعني based on your request. يعني I will focus on the management. This is more important for us as pharmacists, more than the diagnosis, which is usually done by the physician. Yeah, I will present the most important, maybe basic information that any R1, R2 resident should know. Of course, the R3 should know more details and get involved with more debates. But I'll try to present the basics. And if you have any question, feel free to ask. Also, maybe I will ask some questions. Feel free to type in the chat to respond so we can have it as maybe more interactive. So today we're talking about the bloodstream infection with or without endocarditis. This is the focus. And I will start first with the catheter-related bloodstream infection. Okay, first of all, I would like to share with you the guidelines. So if you have a case and you want to check the guidelines, here is the most famous guideline. It is by Infectious Disease Society of America. Unfortunately, the last update was in 2009, so it's very old. It's under update based on their website for a very long time. This is unfortunate, but I just want to share with you the guideline. Still, many information are we applied in practice, but it's not very updated. Okay, first of all, I will not focus on the diagnosis, as I said, more than the treatment. But when you have a case, when you suspect catheter-related bloodstream infection, and then how it is confirmed, without going over the details that sometimes physicians use. So basically, bloodstream infection. So you have a microbe in the blood, bacteria or fungi. Okay, so you have to have bacteremia or fungemia in someone who have intravascular device. Oh, so this is important because some people got confused. The patient is using another catheter that is not intravascular, like urinary catheter, and the patient have bacteremia, so they call the case catheter-related bloodstream infection, and this is incorrect. So this is, I will share some of the mistake I have seen from resident before. Maybe it is helpful for you. So we are talking about intravascular device in the bloodstream, not something like urinary catheter. And to confirm it, we want to see more than one positive blood culture. In the beginning, we're gonna suspect it when, if like any infection, you have the clinical manifestation of infection, which is unfortunately not specific with bacteremia, right? Compared to urinary tract or respiratory, you have some local symptoms, but here you don't have any local symptoms. So the general manifestation like fever, hypotension, or leukocytosis. But here is the important part. When you look in your patient, you don't find any other suspected source. If it's clear, you have urinary symptoms, you have respiratory, then likely it's not catheter-related infection. But if you don't find any source, you don't find any source in your case, and this is the main, this is the only remaining source, mainly the catheter. Then you say maybe it's catheter-related bloodstream infection, and you might start empiric therapy. And we're going to talk about the empiric therapy. What should we cover? And then later we can confirm it when we see the result of the blood culture. Okay, so someone with no apparent source except the catheter, and then we confirm it by the blood culture, more than one blood culture. Then we call it catheter-related bloodstream infection. It's important to classify the catheter-related bloodstream infection. And the main reason is the duration of therapy. Because if it's complicated, then we have to give the antibiotic for long course. This is the main difference. If it is uncomplicated, then we can treat for shorter course. This is the main reason behind the classification. So when do we call it complicated? If the patient have suppurative thrombophlebitis, endocarditis, osteomyelitis, or any possible metastatic seeding in the joint or somewhere else. Yeah, this means that infection going to be more difficult to treat. It's better to extend the duration of therapy. And finally, if someone have persistent bacteremia or fungemia, when do we call it persistent? And then we extend the duration. When? We have to remove the catheter first, because if the catheter wasn't removed, then the persistent bacteremia is likely caused by the catheter, which was not removed. So this is a common mistake. Also, I have seen some people, they call a case persistent and they give long duration, but the catheter was not removed. Once you remove the catheter, then you count 3 days, 72 hours. If the bacteria or fungi was cleared from the blood, that's enough. That means this is not persistent fungemia or bacteremia. So you count from the catheter removal, and then you can call it whether it's persistent or not. The idea is that if the bacteria or fungi stayed longer and was not cleared quickly, this is a sign that you are more likely to have treatment failure and recurrence, and it's better to give longer course in this case. So if you have any case, look at these criteria. If you don't have any of these, you can call it uncomplicated, and then you can give shorter course. Okay, what are the microorganisms that cause catheter-related bloodstream infection? Gram-positive, the most important, including MRSA. Candida, the most important fungi, less likely, but can cause this infection. Sometimes we cover it. And the gram-negative, including Pseudomonas. Now, our focus is the treatment. First, of course, the empiric therapy. If we suspect a catheter-related bloodstream infection, what should we cover? What do we have to cover? Now, all patients, almost all patients, we, of course, will cover gram-positive, but most often we include MRSA coverage. And before we talk about actually antibiotics, the first thing we have to think about is the catheter removal. This is the first thing we should try to do. Some people have doesn't have good access. It's difficult to find access for them, or for any reason, the team will tell you it's difficult for us to remove. Then the case going to be difficult to treat, but this scenario happens in practice. But in most cases, you should be able to remove it. So per guideline, this is highly indicated in some cases. If someone is using short-term catheter, then there is no excuse not to remove, right? Because these are already short-term catheter. They stay only for a few days. You should easily remove those catheter. Unlike the long-term catheter, these are more difficult to change. If you have complicated cases, then you have another reason to try your best to remove the catheter. If you have an uncomplicated case and difficult to remove, you will say it's uncomplicated. Okay, maybe you will try treatment without removing the catheter. But particularly if you have complicated case, you already have higher risk of treatment failure and recurrence. Try with much more effort to remove the catheter. Including the persistent cases, because as I said, when the catheter is in place, this is the main reason for the blood cultures to continue to be positive. So you should try again, talk with the team again. Can we remove the blood culture? Is not, the bacteria is not cleared from the blood. So maybe the reason is the catheter. Please, let's try again. And as I said, the long-term catheter, especially due to some organisms, more risky. Many of them stick with the catheter, like Staph aureus, for example, some form biofilm. Especially for those, we really want to remove the catheter. So it's a discussion. As a pharmacist, you can talk with the team, particularly if you have those cases. Because it's not just about giving antibiotic. Removing the catheter is an important part of treatment. Of course, the guideline will give you the definitive therapy after you have the culture already. Of course, it's easier than empiric therapy. But generally, Staph aureus is the most common bacteria. If it is MSSA, in this case, unlike some simple skin infections, you have to use the high doses most of the time. So for antistaphylococcal penicillin, 2 grams every 6 or every 4, which is a high dose. As you know, for skin, you can use lower, like 1 gram sometimes. But in these cases, go with the high dose most of the times. Also with cefazolin, the 2 gram Q8, not the 1 gram Q8. And for enterococci, as you know, for endocarditis, which I will discuss today, the recommendation is combination therapy until now. But for bacteremia without endocarditis, do I have to combine? Per the guideline, this is debatable. It's not clear. With endocarditis, most authorities recommend that, but for just bacteremia without endocarditis, it is very debatable. So you can use monotherapy, or for selected patient, you can use combination. It is of debate. And like with any bloodstream infection, you have to think about, as you know, some antibiotics, they have very high volume of distribution. So it doesn't stay in the blood and it goes to the tissues. The most important example is tigecycline. That's why tigecycline, it's best not to use it in case of bacteremia. Now, if it is secondary bacteremia, then many people are fine using it. Now we are talking about catheter-related bacteremia or bloodstream infection. But as you know, many bacteremia are secondary, especially with gram-negative. They didn't start with the catheter. No, it came from the urinary tract, from intra-abdominal source, pulmonary, skin. So when you, this is one of the common mistake I see in practice from some residents. Sometimes they say the patient have bacteremia. Although if you look at the patient have maybe skin infection or pneumonia. So we should state the primary source, if it's pneumonia, skin infection, and then we can say with secondary bacteremia. Because when I treat the patient, I treat the patient as the original source, skin or lung, with bacteremia or without, not a big deal, because bacteremia here is just secondary, but we are treating the source. This is the main focus. So if you have secondary bacteremia, it's not
دكتور معلش الصوت انقطع.
wrong.
لسه ما في صوت يجي ويروح.
معلش دكتور صابرين، قطع من عندي ورجع ثاني. لو بس تعطيني الشير.
اي دكتور اعطيتك.
شكرا. Okay, so I was talking about tigecycline. So again, please don't use it for bloodstream infection, except very rare cases, very debatable. If you don't have any option, then some people you double the dose. They use 200 loading, then 100 main with anti as a last option. But otherwise, please don't use tigecycline. Unfortunately, some physicians do that, even some ID consultant, which is not good practice. Okay, as I said, Staphylococcus is the most common bacteria. If it's MRSA, then mostly vancomycin, of course. If it's MSSA, then there is always a debate whether in bacteremia or endocarditis, which to choose, cefazolin or antistaphylococcal penicillin. Always debatable, but practice since long time. Some of them have very strong opinion against cefazolin. They say, no, I have to use antistaph penicillin. This is an old opinion based on all data. We didn't have good data before. Some issues about inoculum effect, but people started to use cefazolin since many years, and it's doing fine. And a lot of centers published their experience, and they compared between the two. And most studies, almost all, they found cefazolin to be at least as effective. We published one of those studies, but there are many more, and there are many meta-analyses looking at the efficacy. No efficacy difference, even in patient with complicated bloodstream infection, even endocarditis, although the numbers are not that big, but cefazolin is not necessarily wrong in these cases. Practice are changing. Many centers switch to cefazolin. And finally, not only the efficacy, and it's easier every 8 hours and less fluid with it, but also looking at the safety. This is a meta-analysis that we published comparing the two together. And we found that antistaph penicillin is more nephrotoxic. As you know, it causes acute interstitial nephritis. Also more hepatotoxic and more hypersensitivity reaction and more discontinuation due to side effect. So based on a number of studies, and in this meta-analysis, this is what we found. So cefazolin is safer. Since it doesn't seem to be less effective, I think many hospitals switch already to cefazolin, and they rarely use antistaph penicillin. There is still some debate, but I would go with cefazolin in most cases. Maybe if someone with CNS involvement or maybe other patients, then okay, then I'm fine with using antistaph penicillin. But other than that, I would use cefazolin as the first line agent. Okay, now about the coverage, as we said, gram-positive, the most important. Why? Because you are having a catheter, and in the skin, we have gram-positive living on our skin, right? So when you use a catheter, you penetrate the skin, then this is what you will see most often: gram-positive. Gram-negative not necessarily covered in all patients. So the guideline has criteria when to cover gram-negative. But most patients covered only for gram-positive, and most of the time including MRSA. Almost all patients should be covered for MRSA, unless you know that your hospital, they don't have MRSA for some reason, then okay, maybe just cover MSA and streptococci. But I think in most hospitals in Saudi, also in US, they have also the same practice, mostly cover MRSA in almost all patients. So almost all patients will get vancomycin. Of course, you have some alternatives: teicoplanin, daptomycin. Now, linezolid, it's less preferred. Not only the side effect, which is a bigger problem if you use it longer, like endocarditis, but one of the RCT found a strange finding, and it's very debatable, and it's not clear if this happened due to chance or because people don't have explanation for this. So those who got linezolid empirically, they had higher mortality. Some of them had higher mortality, but if you look deeper, if you looked at patients with MRSA or gram-positive, they did not have higher mortality. So some people, they avoid linezolid. They say it has higher mortality. This is not true. This is only if you use it empirically, and it happened only in patients with gram-negative, and we don't use linezolid for gram-negative. So it's not clear what is the impact of this, but you will hear people saying, oh, linezolid cause more mortality. This doesn't happen in patient with gram-positive. If you look at the analysis, it happened only in patient who had gram-negative. And we will not use linezolid for gram-negative. But anyway, vancomycin, of course, is the first line. Alternative, maybe teicoplanin or daptomycin, and then you have linezolid. Now, when should they cover gram-negative? Now, we don't want to cover gram-negative in all patients with catheter-related bloodstream infection. But when should we cover them based on the guideline? Of course, when you cover them, because catheter, you are talking like it's mostly healthcare, right? So you cover MRSA, and with gram-negative, you cover Pseudomonas. So you should see mostly ceftazidime or other anti-pseudomonal, not ceftriaxone, for example. Okay, the guidelines say if the patient is septic, then you should cover gram-negative. If the patient is not septic, then focus on gram-positive. But you are concerned in someone with sepsis, then better to cover empirically to reduce the chance of failure and mortality. What else? If someone is neutropenic, as you know, neutropenia increases the risk of Pseudomonas and gram-negative. So in those patients, better to cover gram-negative. And also some types of catheter. So it depends on the type of the catheter. If it's femoral or hemodialysis catheter, also these types increase the risk for gram-negative. So someone with hemodialysis, after hemodialysis, the patient develops fever and we suspect catheter-related bloodstream infection, then we should cover gram-negative. That's why you will see all patients with hemodialysis catheter, they will not get only vancomycin. It's going to be with something that cover Pseudomonas, mostly ceftazidime, because its dosing is attractive in hemodialysis patient because you give it only after dialysis and that's it. So here, this is the cases we cover also gram-negative. Finally, the candida. When do we cover candida? Now, we try not to start empiric candida therapy as much as possible. But in some scenarios, you can consider starting anti-candida. So the guideline provided some risk factors, but it doesn't mean if you have one, you have to start anti-candida. You can wait and see if your broad-spectrum antibiotic works. If not, then you can add antifungal. Femoral catheter. So femoral catheter increases the risk for both gram-negative and candida. If the patient is doing fine, is not very sick, you can just cover gram-negative and wait and watch the patient. No improvement or the case got worse, then you can start antifungal. If someone is critically ill, then mostly you will start antifungal because the patient has high risk of mortality here. So mostly you will start antifungal as well. If you have sepsis, as we said, we have to cover gram-negative, but do we have to cover candida? No. Just being septic without being in septic shock or critically ill, we don't want to cover antifungal. But if someone have some risk factors for candida in addition to sepsis, then maybe better to consider covering candida. We don't have to cover it. We can wait and see if the broad-spectrum antibiotic worked or not. But the more risk factor you have, the more likely that you have to consider covering candida. Number one is TPN. As you know, TPN increases the risk for candida. And if someone received broad-spectrum long duration, then there is more risk for both multi-drug-resistant bacteria and things that are not bacteria, like candida. Also, very immunocompromised patient, hematological malignancy, bone marrow or solid organ transplantation. Also, those are very immunocompromised, and they are not only at risk of gram-negative, but also candida. The last thing in this topic is the antibiotic lock therapy. So something to be considered. I know many hospitals don't do lock therapy. They don't have experience with it, but this is something to bring to the discussion. when should I consider lock therapy? Only if I want to avoid catheter removal. If we couldn't remove the catheter, then you should use lock therapy. Otherwise, you don't need lock therapy. So it's used for catheter salvage when you can't remove it. So you are trying to sterilize the area because this is the source of bacteremia. You want to maybe try lock therapy. And when you give lock therapy, so in the catheter, you are having a very high concentration of the antibiotic. So hopefully it gets rid of the bacteria there and the catheter become clean. And you give it with heparin or citrate, and you leave it for as much time as possible, maximum 48 hours, but at least 4 hours. You don't want to leave it for just 30 minutes and then the nurse use the catheter and then you don't get any benefit. So you want to leave it as long as possible, at least 4 hours. And sometimes, let's say for some reason you can't use it. If you can't use it, then the guidelines say consider giving the antibiotic through the same colonized catheter, not another catheter which is not colonized. If someone have more than one catheter, okay, which catheter was colonized and the culture showed positive finding, give the antibiotic, the IV through that catheter. You don't use it for the whole duration lock therapy, just for the first few days. The guidelines say maybe 10 to 14. Sometimes it depends on the bacteria. But yeah, I just wanted to bring this just for consideration. If you can't remove the catheter, then you should consider suggesting antibiotic lock therapy. Unfortunately, the studies are not very good. Some people don't believe it's, or the efficacy is limited. But many recommend using it. If you can't remove the catheter, it might help some patients. And it is in the guideline as a consideration for those patients. Finally, the duration of therapy. Now in bloodstream infection, it is debatable. Some new paper are challenging this idea, but mostly you count the first day, not from the first day of starting antibiotic, but from the first negative culture. So if you take a culture at certain day, after 2 days, now you have the culture negative, then you go back to the culture when it was drawn, and that is your day 1, not the day you started the antibiotic. Especially for gram-positive, more debatable for other bacteria. If you have an uncomplicated case, as I said, the duration is going to be short. So for gram-negative and enterococci, it's only 7 to 14 days. For Coagulix negative staph, so staph epidermidis, then 10 to 14 days. For Candida, 14 days. And for Staph aureus, at least 14 days if the case is not complicated and if the patient doesn't have also diabetes, is not immunocompromised, doesn't have prosthetic intravascular device, and the infected catheter is not still in place. Then you can give just 2 weeks if you want. But if someone have those factors, better to extend, especially with Staph aureus, it needs long duration. If you have complicated, then you will not give this duration, you will give much longer, mostly 4 to 6 weeks, osteo even higher, 6 to 8 weeks. Okay, I'm done with the catheter related topic. Maybe before I move to the infective endocarditis part, maybe let's see if we have any questions about catheter related bloodstream infection. So one question say, high dose for what? Sorry, it's not clear to me. Cefazolin, yeah, cefazolin we give high doses, always 2 gram Q8, not lower than that. Any other question for catheter related? Catheter related is actually one of the most common infection. In our hospital, we are seeing a lot of cases. What about the duration? So duration, I already commented on it right now, right? So if it's based on the bacteria, right? So it's based on the bacteria and based on the is it complicated or uncomplicated? With staph, there is additional factors, right? Comorbidity, prosthetic device, or the catheter is in place or not, right? So this is about the duration. What is the indication for lock therapy? Lock therapy when you want to save the catheter. If the catheter is in place, so we should consider lock therapy. If we were able to remove the catheter, خلاص, we don't need to do lock therapy. Yeah, for duration, can we consider post-line removal? Yes. And usually when the line is in place, usually the blood will stay positive longer. So yes, many people, they don't count the days the line is in there because likely because you want to count from mostly removing the catheter or if the blood culture is negative, but this is debatable. Some people they count from the first antibiotic, and some people they say from removing the catheter. I think the majority count from removing the catheter, especially if it was removed earlier. They try to count from after removing the catheter. But let's say if someone already received very long course, 6 weeks, and then the catheter was removed, then I don't think you will count from removing the catheter, especially if you use lock therapy and the patient already improved and you didn't have any more positive cultures. Dose of tigecycline bacteremia. Now, we shouldn't use it, tigecycline. It should rarely be considered for bacteremia. But if you had to use it in a very rare case, you didn't have any option, then we should use the high dose, the same one we use in pneumonia. So loading gonna be, instead of 100, it's gonna be double, 200. And the maintenance, instead of 500, it's gonna be 100. So this is the high dose of tigecycline. Okay, for gram-negative, do we need to wait for negative culture? It is debatable. So the guidelines say in general, count from the first day of negative culture, but this is debatable. Some people are even debating this for gram-positive. But it's more important for gram-positive. I think for gram-negative, I don't think it's important. I know many clinicians, they don't believe in the need for this for gram-negative, but you will see some cases people, they will go by first negative culture. So it is debatable. The guideline is old, 2009. Some studies, they use short duration regardless of the first negative culture. The patient did well. So I don't think if someone ignored the first negative culture, this is wrong. No, I'm fine doing that, especially in gram-negative. More important for gram-positive, as you saw, gram-positive, especially staph, you need long duration. So for staph, I would go with from first negative culture or after removing catheter, especially for staph. For other bacteria, I think it's less important. If the bacteria is MRSA, it doesn't matter. If the bacteria is MRSA or MSSA, the duration doesn't matter. What matters is the drug. It's Vanco versus beta-lactam. But duration, just because it's MRSA, no, there is no difference. طيب جرام نيجاتيف جاوبنا عليها. That doesn't matter. يعني MRSA doesn't mean complicated. Complicated, as I said, we have criteria, right? If there is seeding, there is persistent bacteremia, but MRSA or not, it doesn't matter. What matters is the medication only. So you will use Vanco, for example, but you extend duration. But okay, if we treat Pseudomonas, can we use ciprofloxacin monotherapy? Yes, I'm totally fine with doing that. But you will see maybe some physician, they don't like oral medication, for example. Although newer evidence suggesting oral therapy, especially if it has good bioavailability, it seems to be okay, especially with continuation. Maybe you started IV beta-lactam in the hospital, maybe ceftazidime for Pseudomonas, blood cleared. So for me, I'm totally fine with discharging the patient on a good dose of Cipro 750 Q12 and making sure the patient is not taking divalent, trivalent cations. For me, I'm fine doing that. And a lot of studies got published comparing oral therapy versus IV, including gram-negative, and people did fine. So if the case is not too severe, I'm totally fine doing this, especially after receiving a few days of IV therapy. Lock therapy, different antibiotic use for lock therapy. Vancomycin, one of them, ceftazidime, gentamicin, daptomycin, a lot of antibiotics. And if you go to the guideline, there is a table of some antibiotics that can be used. And there are some review articles that give you even other antibiotic that is not in the guideline table that also was studied and used. Okay. Yeah, the culture ideally should be repeated daily until it's negative. So I would repeat it every day, especially if you want to count from the duration, because you don't want to wait 1 week and then you take a culture, it's negative, but you don't know when it became negative. So ideally, it should be every day until it become negative. Type definition will not focus on the definition, although it's important, but we leave this better to the physician. And there is a lot of details, so it's not the focus today. But yeah, sometimes we have to look, is it from peripheral, from central, time to positivity, but maybe not the focus today. What about inoculum effect of cefazolin? Yeah, what we care about is the clinical outcomes, not in vitro phenomenon. Okay, this was the concern with cefazolin before, the inoculum effect. And then you see higher MIC, maybe more risk of failure. But when people used cefazolin in practice and published studies, what happened? Did they fail? No, they did as fine and sometimes better than anti-staph penicillin. So inoculum effect or no inoculum effect, what matters is the clinical outcome at the end. If people improved and the clinical efficacy is good, it doesn't matter whether inoculum or something in vitro, bactericidal, static, all these are less important. What we care about is the clinical outcome. Since long time, okay, people said inoculum effect, so they avoid the cefazolin. With time, they used it, and it proved to be as good in majority of cases. So I wouldn't care about this inoculum effect. I think this is something old, unless it proved this in clinical outcomes. Can we switch the patient to linezolid? Yes, we can. Although some physician will tell you, no, we can't. And this is because, number one, as I said, there was a warning about linezolid for suspected catheter-related bloodstream infection. But as I explained, if you go and look at the data, it didn't happen with patient with gram-positive infection. If you look at the study, they did not have higher mortality. Some patient with gram-negative, who end up having gram-negative, they had higher mortality. But MRSA, there is no proof that they got worse outcomes. Also, some people say it's bacteriostatic. That's why I will not use it. Also, this is one of the old myths. Okay, it's not very important. Before we used to say static sidle, but what matters is the clinical outcomes. What matters is mostly the pharmacokinetic properties of the medication, not just static or sidle. Plus, one of the famous recent systematic review and meta-analysis, they looked at all RCTs that compared bactericidal versus bacteriostatic. What did they found was static less effective? No. Overall, similar efficacy. And the only one study which found worse outcome was static. It was because the drug was tigecycline, and likely because we need a higher dose in pneumonia for tigecycline, likely. So this is a likely cause of more kinetic, the dose, not static versus sidal. And in 6 of the studies, actually the static medication did better than bactericidal. So static and sidal, this is an old discussion. Unfortunately, many clinicians still use it a lot today, but it needs to change. And you will see a lot of recent paper discussing this. This is a myth. We should not focus too much on this. So linezolid, I think it's acceptable. I'm not saying we have the best data, but a lot of centers start using it, and a few studies got published, comparative studies. Unfortunately, they are not RCTs. We only have a pooled analysis from RCTs, but most of them, they have secondary bacteremia. Linezolid did as good. And we have observational studies in case of bloodstream infection. Many of them have catheter-related or primary bacteremia. And in all of them, in none of them, linezolid did worse, except one of them. But if you look at all the others, and the one with better quality, linezolid did at least as good, especially if you switch later to linezolid. None of the studies showed a worse outcome with linezolid. So we don't have the best data, observational studies mostly. But linezolid is acceptable. I'm not saying we should replace vanco with linezolid. Vanco is the first line, but sometimes we see people keeping the patient in the hospital, and they say, I can't discharge the patient. Patient need vancomycin, or we don't have OPAT. This is not an excuse. You can discharge the patient with linezolid. So linezolid is not contraindicated as many physicians think. And if you search, you'll see a lot of papers saying the same thing. So it's an option. The main issue with linezolid actually is not the efficacy, but the side effect. And for this side effect, you can monitor the patient. So it's not a contraindication. You can monitor the platelet and the other side effect. If the patient develop severe thrombocytopenia, okay, then you can switch to another medication. But it's not a contraindication just because of duration that you can't use in any patient. No, you can give it and monitor the patient in many cases, especially if we switch after maybe receiving a few days of vanco, and then you want to switch and discharge the patient. I think this is better for patient than keeping the patient in the hospital, increasing the healthcare cost, and taking the time from the nurse and the team. And the patient might acquire hospital-acquired infection or complications or catheter-related complications. So if you don't have OPAT, especially, I recommend you consider using linezolid oral at discharge more than keeping the patient for a long time in the hospital. Okay, if we don't have more question, we can have a break if you want, maybe 10 minutes. And then I can start talking about endocarditis.
تمام دكتور، 10 دقايق بنرجع بإذن الله.
طيب السلام عليكم.
وعليكم السلام، يا هلا.
يا هلا. طيب نبدأ إن شاء الله نكمل. Now we'll discuss the basics of the infective endocarditis. Of course, you can have catheter-related bloodstream infection, and then it causes endocarditis. So first of all, like before, I will share with you the guidelines. If you want to read it, we have two main guidelines, one American, one European, both published in the same year, 2015. One by the American Heart Association, endorsed by the IDSA. And then you have the European Society of Cardiology, and it's endorsed by a number of organizations. But now you have European, US. They agree on the majority of recommendation, but for some recommendation, maybe there is a difference. And mostly it's caused by the lack of evidence, because endocarditis is rare, it's not common. It's very difficult to do a study. And if you do a study, it's going to be a small sample size, and that's why maybe the debate in the majority of cases. So as an introduction, infective endocarditis is an infection of the endocardial surface of the heart, mostly heart valves. And with it, you have high morbidity and mortality, especially the left side. You can have complications like embolism and heart failure. So it's a serious infection. And, as we said, we will not focus on the diagnosis. It's the job of the physician. But just quickly, again, no specific signs of infection. Sometimes, someone might have a new murmur, or maybe the patient have it before, but it got worse. But nothing major that is clear from the beginning. We need to do really the echo to confirm or not. So with the echo, you can see vegetation, and it's usually larger if you have fungal infection, or you can see abscess. You have two types, as you know, of echo, TTE and TEE. With TTE, you might not see the vegetation depending on where it is. TEE is the transesophageal. It's more invasive, but more sensitive. Frequently, they try TTE and then they do the TEE. And then we will see if there is endocarditis or not. Without going over the details, just to share with you that there is something called modified Duke criteria, and based on it, you can say if it's definitive or possible or not. But basically, the more you have, if you have measured criteria, if you have, for example, 2, now it's confirmed. If you have 1 plus a number of minor, then you might have also endocarditis. So this is the criteria just for your information. But as you can see, the main one that is major, if there is a bacteria that is consistent with endocarditis, then this is a major criteria. If someone has Pseudomonas, then this is not major because this is not consistent with endocarditis. But if you have MRSA, then it's consistent. For example, if you have evidence of endocardial involvement, if the echo is positive for endocarditis, or you have new valvular regurgitation, this is clear that you have endocarditis. Okay, I will not go over all the criteria. This is mostly for the physician to diagnose, but just wanted to share with you because you might hear it during the round. Our focus is the treatment as pharmacist. So sometimes surgery help, depending on the case, especially if someone have a prosthetic material, then they might want to change it. And for the antibiotic therapy, as I mentioned, bactericidal, bacteriostatic, it's very debatable, not a big issue mostly. You might read it in some references, but as I said, it's not the most important thing. Typically, in these cases, you want to use the highest dose. with the majority of antibiotics. So you will see high doses. And with endocarditis, compared to uncomplicated bacteremia, you're going to see long duration. So any endocarditis, most of them you will need a very long duration. Sometimes the duration or choice is affected by whether the valve is native or prosthetic. Sometimes, not always. Sometimes we'll mention some cases. And some patients have culture negative endocarditis. So not in all cases you will find a blood culture. Sometimes you will not find a blood culture. It's negative. But they did an echo and there is a confirmed endocarditis. So you call this culture negative endocarditis. Why it happens? Some organism doesn't show easily on culture or takes long time. And sometimes because the antibiotic that are already started, they suppress the bacterial growth and you don't see it in culture, or even though there is a bacteria causing endocarditis. The issue here is that you don't know what to start and you have to give something broad because you don't have the exact organism. And in most of these cases, when you start empirically like this, you cover, of course, gram-positive, including MRSA. And at least you cover, the gram-negative, the HASIC organism mostly, because Pseudomonas is not important. It's rare, except if someone have like a surgery and then they develop infection, endocarditis, then you cover Pseudomonas. But most of the time, you will see ceftriaxone plus vancomycin in the majority of typical cases. Mostly it's based on the bacteria, and most of the time you will see a bacteria isolated in the blood culture. So let's start with the gram-positive, the most important. When you talk about streptococci, now, as you know, streptococci, we have different species. When you talk about streptococci group A, pyogenes, or group B, they don't have resistance, right? So, simple beta-lactam will work on them. But with the ones mostly causing endocarditis, like Viridans group, bovis, or Garruloticus, now, sometimes you have resistance. Most of them are susceptible. That is good, but you have to check because they can be resistant. Now, if it is susceptible, if it's highly susceptible, then you can choose any beta-lactam, any simple beta-lactam, even just penicillin G. Just alone most of the time. There is an option to add gentamicin and reduce the duration. In some cases, not all cases. If you have, a severe allergy, then of course you will go with vancomycin. You will change the class. But if you have just rash from, maybe amoxicillin, you don't have to avoid the other beta-lactam. You can still give beta-lactam. The cross-allergy risk is low. If the reaction is mild, like rash, then don't worry, you can pick something else. So if you give ceftriaxone, for example, for someone with amoxicillin rash, it's fine. You shouldn't go with vancomycin. You can try beta-lactam. So one of the myths some people have, unfortunately, that if you have allergy from one beta-lactam, you can't use the others. This is incorrect. Mostly apply this when you have a severe allergy. But if it's not severe, you can pick another beta-lactam, especially if it's a different class and the side chain is different, then it's fine. If it's relatively resistant, or you might call it intermediate, then we can't just give the beta-lactam alone with the same dose because you have higher MIC. So what do you do in this case? Number one, you increase the dose. Number two, in this case, now you have to add gentamicin, because gentamicin alone cover only gram-negative. But if you combine it with cell wall active agent like beta-lactam, there is a synergism, and it is used particularly with some endocarditis cases. So beta-lactam open the cell wall, and then the gentamicin gets inside and work on the protein synthesis. So this might increase the chance of efficacy if someone has highly susceptible bacteria, streptococci, then you don't have to use this. If you use it, then you reduce the duration. But with relatively resistant, you increase the dose, and also you are trying to maximize the efficacy, and you combine with gentamicin. Now, the reason that higher dose still work is because, when you look at streptococci, the mechanism of resistance is by reducing the affinity to penicillin binding protein. So you have reduced affinity. You don't have like another mechanism. So how do you overcome reduced affinity? You can just increase the dose. So this is how it works. In endocarditis, you combine with gentamicin. But for example, if you have community acquired pneumonia, you can give high amoxicillin or augmentin dose and overcome the intermediate species. In endocarditis, as we said, you will see commonly the combination with gentamicin, but not in all cases. With certain bacteria like enterococci, or with more difficult cases, like here, if you have higher MIC. Again, if it's severe allergy, vancomycin. And in this case, it's debatable. The European guidelines say also add gentamicin to benefit from synergism. American don't say that. The issue with it is that you increase the risk of nephrotoxicity because both are nephrotoxic, but maybe it's more effective. It's not clear. So a debate here, but vancomycin is the most important option here, with or without gentamicin. If it's fully resistant, then you don't have an option. You can't use beta-lactam here. If it's resistant to all beta-lactam, then you have to go with vancomycin anyway. With or without gentamicin, this is a debate between American and European guideline. The last thing is the duration. For streptococci, it's not the longest duration. It's longer for other bacteria. Some exceptions. If you have prosthetic valve, then the American guidelines say let's extend it for 6 weeks. European don't have this recommendation. And as I mentioned before, if you have highly susceptible bacteria, then you can use the combination with gentamicin and reduce the duration from 4 to 2 weeks. But you do this only in patient with low risk of nephrotoxicity, because it doesn't make sense to give gentamicin and do this approach in someone with AKI. And also the case need to be not the most difficult and complicated case. The non-complicated cases of endocarditis, no complications, then you consider this and reduce the duration, and the patient can finish the course sooner. And for relatively resistant or penicillin resistant streptococci, as I said, you increase the dose and you combine with gentamicin. How long? This is debate between European and American. European says just 2 weeks is enough. We don't have to continue the whole duration. But the Americans say maybe better to continue the whole duration. So both together, the beta-lactam with the gentamicin. The next bacteria is staphylococci. Now, if you have MSSA, as you know, of course, we either as anti-staph penicillin or cefazolin. There is a debate. Some people, in this case, they say it's severe endocarditis. They might go with anti-staph penicillin, but growing evidence showing cefazolin is as good, even when they looked at endocarditis cases. It seems to be doing fine, but again, some physicians like anti-staph penicillin in these cases. MRSA, or if you have severe allergy from beta-lactam, then of course vancomycin, the drug of choice, and you have alternative medication like daptomycin, even ceftaroline, which is available in Saudi market, approved, but most hospitals don't have it yet, mainly because of the price. It is, by the way, as available as an option in the European guideline. American said at that time it's too early to recommend it. European says it's fine. It's there as an option. Linezolid, it can be used. It's not wrong. The issue is the limited data. now we have more data with bacteremia, but with endocarditis, the data is limited. Some people say it should be fine. If it worked for bacteremia, it should work for endocarditis. And some people say we want more data. So, the debate that I mentioned, but it's not necessarily wrong if someone wants to use it. The main issue is the side effect, because endocarditis, you're going to treat for long duration. So can the patient tolerate linezolid? This is a question. This is the main limitation here. Unlike, bacteremia, as I said, you can treat for 2 weeks, 3 weeks sometimes. So less likely to see the side effect. Now, this is with native valve endocarditis, but prosthetic valve, this is important for us as a pharmacist to pay attention to the type of valve, because with staph aureus can cause biofilm with prosthetic material, not only in the heart valve, but also with, as you know, prosthetic joint or prosthesis in the CNS. The same approach. We are worried about the biofilm, and the antibiotic might not penetrate well. The best antibiotic that does that is rifampin. So the same approach like any other infection, any place with prosthetic material, you add rifampin to penetrate the biofilm. And again, this is endocarditis. As we said, in the most difficult case, we combine with gentamicin for synergism. Now, if you can't use gentamicin, maybe AKI patient, now only the American provided fluoroquinolone as an option, although it's mostly expert opinion. No great studies that support good synergism between fluoroquinolone and beta-lactam. Also, one of the newest regimen, it's not available, maybe it's not detailed in the guideline because this was published 2019, so after the guideline. But this is one of the promising combination, and it's available orally. This is also a nice thing about it. So high dose cotrimoxazole with clindamycin. In this study, it was promising. So some people start to use it in some selected cases. Some people say still it's early, I want to see more data. I just want to share with you, as an option of oral medication in some cases, maybe. Duration of staph is longer than streptococci. It's 6 weeks. Except if you have right side, these cases are simple, especially if it's uncomplicated. Then the guideline provide an option of just 2 weeks. So if you have uncomplicated right side, it's fine to give a short course, only 2 weeks. Other than that, if it's complicated, if it's left side, then you have to give the long duration 6 weeks. And for prosthetic valve, at least you give 6 weeks, and frequently it's longer, 8 weeks or maybe longer, depending on the case. And in this case, you have to combine with gentamicin, as I mentioned. But gentamicin here is not continued for the whole duration. It's only the first two weeks. And then you continue with the main drug. The last gram-positive enterococci, drug of choice is ampicillin. But it's combined here in all cases, not in some cases like before, with aminoglycoside, gentamicin. Resistant to ampicillin, then use vancomycin, also with gentamicin. By the way, one of the aminoglycoside, streptomycin, it can cover some gentamicin-resistant enterococci. So consider it as an option if you have gentamicin resistant, or you can just use the newer regimen, ampicillin ceftriaxone. So this is one of the newest regimen. Many physicians don't know about it. Until now, we see physicians that are not aware about this regimen, even though it has been in the guideline 2015. Because this is not one of the old regimen, this is one of the update. Some studies was published before the guideline, and based on them, I think now there is at least 3 studies, all of them, of course, observational, but it showed, that ampicillin ceftriaxone seems to be as effective as ampicillin and gentamicin, and it's safer, of course. So they say if someone, especially with creatinine clearance less than 50, or already developed nephrotoxicity after starting gentamicin, then they say better to use ampicillin ceftriaxone. You will see some hospitals which switch already to ampicillin ceftriaxone for all patients, and some people say no, this is a new regimen. Most experience and evidence is with Genta, so they stick with Genta. But yeah, I think we should start using this regimen, ampicillin ceftriaxone, at least in patient at risk of nephrotoxicity or resistance to gentamicin. Now, if it's resistant to all of those, VRE, vancomycin-resistant enterococci, then we have to use daptomycin or linezolid. Maybe daptomycin a little bit preferred because we are giving it for long duration. Maybe it's safer than the long-term side effect of linezolid, but both of them are options. There is a debate whether to use daptomycin alone or in combination. One guideline say combine with ampicillin. I think the European and the American say plus minus. But the key here, as I will mention, is the dose. You have to use high dose of daptomycin. Duration here is between staph and strep 4 to 6. But if you have VRE, then you have to give even longer. VRE is a nightmare. You don't have a lot of medication, as I showed, mostly dapto and linezolid. If they become resistant, we will lose almost any option for VRE. So therefore, if you have VRE, this is a big issue. Safer to give very long course to make sure we get rid of it. Because if the patient develop resistance, this is a big issue. And we don't have medications for this bacteria. We are done with gram positive. About the gram negative, the most important is the Hasek organism. These are the names, so each letter is an abbreviation for a bacteria, but none of them is Pseudomonas, right? So when you treat, you don't need anti-Pseudomonal beta-lactam. You give ceftriaxone or ampicillin or Cipro for 4 to 6 weeks, like many enterococci. And this is what we cover when you give empiric therapy. That's why we give ceftriaxone mostly. Now, the non-Hasek gram negative, they are very, very rare, and we rarely consider them. Mostly if someone have surgery, then we cover Pseudomonas. But Pseudomonas to cause endocarditis, that is very, very rare. And in these cases, if it happened, it means that maybe we need surgery. And it's not clear whether we need combination or not. The guidelines say maybe safer to use combination, although it's debatable. Now the doses, I just want to highlight some doses. Now, if you use penicillin G, for highly susceptible bacteria, you just use 12 to 18 million units per day. But if you have intermediate, then or have prosthetic valve, the recommended dose is much higher. It's 24. And for enterococci, it can reach even higher. But mostly enterococci, we use ampicillin. So yeah, so the doses, if you use penicillin, pay attention to the case. The dose can be different. Anti-staph penicillin or ampicillin, you use the highest dose, 2 gram Q4. Cefazolin also the highest dose, 2 gram Q8, like bacteremia. Ceftriaxone, now it depends. If you use it for streptococci or gram negative, then use the regular dose, 2 gram once daily or 2 gram per day. But if you use it for enterococci in combination with ampicillin, now the studied dose is higher. It's 2 gram Q12. So like meningitis, the same dose, the high dose, 2 gram Q12. Daptomycin, this is important because the approved dose is lower, like 6 milligram per kilogram. But please, in endocarditis, you need to use higher dose. Even in bacteremia, you need to use a higher dose, but even higher with endocarditis. The Europeans say 10 milligram. So as you can see, it's almost double the regular dose. Americans say at least 8 for staph and at least 10, up to 12 for enterococci. So this is important. You need to use high dose of daptomycin. lower dose proved to be less effective in case of bloodstream infection. So please don't use the approved doses of daptomycin, use higher doses. By the way, can you use oral therapy for endocarditis? Many people will say, no way I will use oral therapy. By the way, there is an RCT that was published that showed oral to be, if you switch to oral, it's fine, it's as good as IV. But if you look at the study, they didn't include the patient, the sicker patient, the unstable patient. No, they had to do a lot of exclusion to include the less sick patient, the stable patient. So don't use it, as IV in all patients. No, the less sick patient, you can consider switching to oral. It's not totally wrong. Although you will hear some physicians, they will say, no way I will do that. But based on this study that was published in NEJM, oral therapy did fine, at least for the patient who are, they have endocarditis, but they are less sick and they are stable. After stabilization, they switched to oral therapy and they did as good. The last thing is the prophylaxis for high-risk dental procedure. As you know, dentists, unfortunately, they overuse prophylaxis in dental procedure. Some people say, if you have cardiac condition, I have to give you prophylaxis. This is wrong. And some people say, if you have tooth extraction or root canal, I have to give you prophylaxis against endocarditis. Also, this is wrong. So the guideline keeps reducing the indication, but mostly you need to have both. You need to have some cardiac conditions, like congenital heart disease, prosthetic valve, previous endocarditis. So those high risk severe cardiac condition, if you have them, you need to add also the patient need to have high risk dental procedure, increasing the risk of bacteremia, and then you can consider prophylaxis. So if you are having high risk dental procedure like tooth extraction, root canal, periodontal surgery, so those that that's invasive, requiring manipulation of the gingival or periapical region of the teeth, or perforating the oral mucosa, then okay, you have high risk of bacteremia. Is it enough? No. You also need to have some cardiac condition. If someone doesn't have cardiac condition, then you don't need prophylaxis. So you need to have both, and then you can consider prophylaxis. Other than that, we don't need prophylaxis. What do I cover in prophylaxis? You need to cover the bacteria in the mouth, which causes endocarditis, which is the very dense group streptococci. You give just a single dose. You don't continue post-operative antibiotics. This is wrong. Just single dose before the surgery. Most of the time, amoxicillin or cephalexin is the main drug, because we are covering just the streptococci. We don't care much about maybe anaerobes or gram-negative, just mostly the streptococci. This is the main antibiotic. Okay, now I'm done with the endocarditis as well. So now we open the floor for questions. For the antibiotic MIC, MIC is used to determine, if the bacteria is susceptible, intermediate or resistant. The majority of MRSA, they have around the world, not only in Saudi, they have an MIC of 1 or less. So in this case, vancomycin is a great option. But if it's higher than 1, then you start to see issues. And then vancomycin might not be the best option. And that's why, if you look at the new guideline, they recommend area under the curve for consideration. And it's AUC over MIC, but most of the time we don't look at the MIC, or we assume it's 1, because this is the reality around the world. Most staff always have 1 or less, so you can ignore the denominator and just use 400 to 600 as your AUC target. Any endocarditis questions? Any question about endocarditis? Okay. If we don't have more questions, I think we're done. الله يعطيكم العافية. شكرا للدعوة وتشرفت أكون معاكم وأتمنى لكم كل التوفيق إن شاء الله في الريزيدنسي وما بعد الريزيدنسي.
شكرا دكتور، الله يديك العافية.
الله يعافيكم.